honor. It's always an honor to present in front of my teachers. And here, what I'll be presenting is what I've learned from Chitra. So I'll be presenting few of my interesting cases and one interesting diagnostic case, how we handled or treated it. So case one, it's a 76-year-old male. He has a triple vessel disease. He had undergone a carotid endarterectomy on the right side. So he had a significant stenosis on the left side, and he had it was a symptomatic stenosis with a TIA on the left hemisphere. So he was referred for carotid stenting. So CT shows a thick, chunky calcification in the carotid bulb on the left side. The right is already treated. The right was already treated. He underwent endarterectomy. Here, the left was the one which is symptomatic. It shows a thick calcified plaque. Now, if these are the serial axial images, it is actually a discontinuous plaque. So, in the lower part, it is only along the posterior aspect. It is V-shaped along the posterior aspect, probably measuring around 2 millimeters in thickness. And as we go higher, it becomes near circumferential, but still it is incomplete. So though it looked a very calcified plaque, we still went ahead and offered him carotid stenting. And so this is a intracranial angiogram prior to the stenting. So you can see that there's a shift in the watershed, which is shifted more towards the lateral aspect. The ACA is not visualized, very faintly visualized ACA. So this is the angiogram showing a tight stenosis, which is measuring more than or close to 90%. The stenotic segment crossed with the filter wire. So the filter which I used here was an EmboShield NAV6. So crossed distally and placed in a safe place. And this is after angiogram after the filter placement. So did a preplasty of the stenotic segment prior to the placement of the stent. So used a 3 into 12 mm coronary balloon. So in spite of, these are the images after multiple plasty. So in spite of multiple plasty, the luminal diameter didn't increase. So this is the plasty with the balloon place. In spite of balloon inflation, the wasting in the balloon is not going off. It is, the stenosis is still persistent. So so this is a video. So this is a video. See, this is a stent which is trying to be navigated through the stenotic segment. The nose cone of the stent was getting stuck. In spite of repeated efforts, I was not able to navigate the stent through the stenotic segment, across the stenotic segment. So the next option was to use a non-compliant coronary balloon. So did an inflation up to 18 atmospheric pressure, not much of change, and then did an inflation up to 20 atmospheric pressure. And then this is a video of the stent being navigated to the stenotic segment. You can see the jerk. With a jerk, the stent could be passed across the stenotic segment and the stent is placed. Now the stent is placed, have got an adequate opening of the stenotic segment. The next was retrieval of the filter. So was not able to retrieve the filter because while pushing the retrieval catheter, the catheter was getting stuck at this side. This was an open cell stent. Because of the fish scaling of the stent struts at the stenotic segment, the retrieval catheter was getting stuck. So in spite of rotating the neck to the other side, it was not possible. So this is the video of how we navigated it. So what we did was first took a curved diagnostic catheter, which is a 7 French diagnostic 7 French guide catheter. This is a Jerkin's right or right coronary guide catheter, 7 French. So navigated it slowly into the stent, and once it was closer to this site of the stenosis, a balloon was passed across this guide catheter. Balloon was inflated, and with the inflated balloon in place, the catheter was navigated beyond the stenotic segment. So what this did was that it pushed the stent struts and allowed the catheter to pass. So once the catheter was beyond this segment, then the stent balloon was removed and the filter was retrieved. So So this is a angiogram post retrieval of the filter. It's a good opening of the stenotic segment, and if you look at the intracranial flow, the ACA is now visualized. So there is an medial shift of the watershed. So this is an angiogram pre and post stenting. So you can see the difference. So post stenting, there's an angiographic shift of the watershed to the medial aspect and better visualization of the MCA. ACA. Now, case highlight, though calcified plaques are better handled by endarterectomy, the idea of showing this case was not to say that even in spite of having a calcified plaque, it is you should offer carotid stenting. The idea was only to say that these are the challenges which you will face when you're trying to treat a calcified plaque, especially when it is thick and especially when it is circumferential, and use improvisation so that you can overcome the difficulties, like using a non-compliant balloon, using a balloon with a higher atmospheric pressure, and also using catheters so that you can navigate, or using techniques so that you can navigate the difficult stenotic areas and then retrieve the filter or retrieve the device. The second case, it's a 49-year-old female, hypertensive, anemic, presented with a sudden onset left-sided weakness. So the onset of symptoms was 1 hour. The other symptoms which are also associated was headache, which was preceding her symptoms of 1 day duration. So NIH's at presentation was 8. Now this is the diffusion. So there is subtle diffusion restriction which is seen involving the predominantly the white matter in the right cerebral hemisphere. This is the B1000 and B2000 images. So the findings are more apparent on the B2000 images. Also, what we can see is a very subtle finding of diffusion restriction, again better seen on this ADC map in the contralateral hemisphere. Again, both the hemispheres, the diffusion changes are involving the white matter. Flare, there is no corresponding changes on flare. If you look at the SWI, the prominent veins are seen in the right cerebral hemisphere compared to the left. Now, flare vascular hyperintensity is seen within the ICA in its petrous segment, and also in the MCA branches in the sylvian fissure. The arrow marks just to highlight the flare vascular hyperintensity. No corresponding changes on flare, and if you see that there is a significant perfusion defect because there is prominent cortical veins on SWI. Angiogram, both ICAs are not seen. On the right side, even the intracranial arteries are not seen, whereas there is faint filling of the intracranial arteries on the left side. So this is a faint filling of the intracranial arteries on the left side. So I was not sure what is the etiology of the stroke, at least based on the imaging, because she was within the window. IV TPA was given and then taken up for mechanical thrombectomy. So the angiogram on the left side, you see a very small caliber left intracranial, left cervical ICA, which is ending at the supracoronoid segment. And on the right side, there is opacification of the proximal cervical ICA, and then a segment in between is not seen, and then there is opacification of the supracoronoid ICA. This opacification is through the collaterals via the ophthalmic artery. So the ECA to ophthalmic artery, and then opacification of the intracranial. And then there is very delayed filling of the rest of the cervical ICA. So it's a delayed filling of rest of the cervical ICA. Again, even in spite of the delayed filling, we are seeing a segment where there is no filling happening. So this is a delayed antegrade filling, and this is the delayed retrograde filling. So this is just a zoomed image. Then cross that occluded segment. If you can see, it's a young patient, but still the artery is very tortuous for her age. The microcatheter injection beyond the occluded segment shows that the right-sided MC and ACA branches were patent. So placed a stent reaver and did both an aspiration and a stent reaver or a combination of aspiration and stent reaver for the occluded segment, which was in the distal cervical ICA. So this is after the first pass. There's persistent occlusion. There is no good intracranial flow. So this arrows showing the placement of the stent reaver, and this is the aspiration catheter. Now, looking at this, in spite of non-recanalization of the occluded segment, plan to did an angiogram with a stent in place, and it showed that the vessel was patent after placement of the stent reaver. The stent, I mean the stent reaver. So this confirmed that probably it must be a dissection flap in that region. So went ahead and placed a coronary stent in that region. So this is a coronary stent which has been placed, achieving opening of the blood vessel. But because of this tortuous anatomy requiring multiple push of the deploying catheters, there was an iatrogenic dissection which was involving the proximal cervical ICA. And then that segment also was stented. So the stenting of both the proximal and the distal cervical ICA segments done, achieving a good opening of the stenotic segment, stenotic or occluded segment. So this is the antegrade flow in the cervical ICA, and this is the antegrade flow in the intracranial ICA, intracranial vessels. So this is the intracranial angiogram. So the contralateral hemisphere is supported by the pial collaterals which are coming from the ACA. The MCA is supported by pial collaterals coming from the ACA. So post-procedure, she had complete recovery. The NIHS has dropped to 0 at 12 hours. And this is a follow-up MRI. Now, if you look at the pre-MRI, which showed this diffusion changes, there's complete reversal of the diffusion changes on the follow-up MRI, which was done at 24 hours. And this is an angiogram just before discharge, and the patient on the first follow-up. She had complete recovery without any deficit, with the angiogram showing persistent opening of the neck and intracranial vessels. So this is a case of stroke in young. Hyperacute diffusion changes were seen in bilateral cerebral hemisphere. That's why we could achieve reversal of the diffusion changes with timely treatment. Now, retrospectively, when we look at the flare, there was a flap which was seen within the flare vascular hyperintensity, the intracranial ICA. So probably this should have suggested us that it was more of a dissection rather than an occlusion, because usually IV TPA is not a option or treatment which is given as a bridging in patients who have a dissection causing a stroke. So probably this got missed on initial evaluation. And this is a case of bilateral ICA occlusion, probably bilateral ICA dissection, one which is chronic and one which is acute. Looking at the tortuosity of the vessels, we thought that she must be having some underlying connective tissue disorder, but all her workup did not suggest anything. So finally, this was a case of bilateral ICA dissection, one acute and the other chronic. And at presentation, because of presence of only one vessel supporting both hemispheres, had infarcts which are present in both hemispheres, and which and with the reversal of the diffusion changes after recanalization or restoration of the intracranial flow. Third case, it's a 24-year-old male who presented with episodes of LOC and headache. CT showed a fourth ventricular bleed. So the evaluation was done to look for a cause for the bleed. The imaging of the brain did not pick up any intracranial cause for the bleed. So the spinal imaging was done, which showed a spinal vascular malformation. Clinically, he didn't have any neurological deficit, but severe radicular pain in both lower limbs. So MRI showed a spinal AVM, which was at L1 level with subarachnoid hemorrhage in the spinal canal. So this is MR images. So T1 weighted images showing a subarachnoid hemorrhage. So this is a cluster of vessels which is showing suggesting an AVM, and the flow void seen on T2 weighted images. So the predominantly the AVM is in the conus medullaris and cauda equina region. Angiogram. So there were 4 radiculomedullary branches which are supplying the AVM. So 2 on the right side and 2 on the left side, and with venous ectasia at the in the draining vein. His pelvic angiogram also showed that there was a vascular malformation, which is a diffuse vascular malformation in his pelvis. So this is a arterial feeder and the venous drainage. So just a diagrammatic representation. So he had supply from the radical medullary branches, which was one anterospinal and 3 posterior spinal arteries, and a very complex AVM in the pelvis. So overall, it is a spinal AVM with a pelvic AVM. So mostly a spinal arteriovenous metameric syndrome. So this is a photograph of his gluteal region. So this region was hard, and there was skin pigmentation predominantly on the left side, and also some skin pigmentation on the opposite side. So what are the treatment options? Do we embolize the AVM, or do we wait for, do we do a conservative management, as patient had only radicular pain, no neurological deficit, and he had, though he had presented with subarachnoid hemorrhage. So what we planned to do was to do a provocative test and do an embolization. The plan of provocative test was done or thought of because we wanted to completely embolize the AVM in a staged manner, so that during the embolization we could at least pick up if there's any drop in, whether there was any lack of blood supply or occlusion of the vital vessels, or was it producing any significant clinical significant loss of this vital function while embolization. So this is how we went through. So microcatheter was positioned as close to the fistula site as possible, and propofol and lignocaine were used for as a provocative test. So 5 milligrams of propofol was injected through the microcatheter from the desired or the probable site from where we will do a embolization, and then we did a neurophysiological monitoring, which included motor evoked potential and sensory evoked potential monitoring before, during, and post this injection of this infusion of this propofol. We waited for 5 minutes, and if there was no change in any of this waveforms, then 2%, 15 ml of 2% lignocaine was injected through the microcatheter. Again, the monitoring was continued. And if there was no change in any of these waveforms, then we went and embolized from this site of microcatheter position. And all during the embolization, the monitoring was continued just to see that if there was any drop in any of these evoke potentials, then we would stop our embolization at that time point. Now, why propofol and lignocaine is because propofol is known to reduce the neuronal activity and lignocaine is known to reduce the axonal conduction. So both are required for us to assess that embolizing a vessel at that particular site, would it cause any neurological deficit? So first went into the posterior spinal artery feeder, did the provocative test with propofol and lignocaine. And this is just this one on brief on a neurophysiological monitoring. For motor evoke potential, the scalp electrodes are placed over the scalp, through which the electric potentials are passed, and then the signals are received at the limbs, like the organ which we want to look for. Like if you are looking for potential from the lower limbs or upper limbs, same way, sensitive potential is by placing the electrodes in the distal limbs, and the potentials are received from the electrodes, these scalp electrodes placed on the scalp. So these are the baseline traces of sensory evoke potential, and that is pre-infusion of the lignocaine. And this is tracer obtained post lignocaine and propofol infusion. Just to show that there was no change in the evoke potentials when a provocative test was performed. And then we did a staged embolization. First, we in the first sitting embolized only 2 feeders and called back the patient after a certain duration of time and embolized the other feeder. So first feeder, which was embolized, so this is a microcatheter position placed as close to the nidus as possible, and then provocative test performed and embolized. So here this is the embolization from the second feeder. The first sitting of embolization, because we wanted more percolation, we used squid rather than glue. So this is after the first sitting of embolization. The second sitting of embolization was done after a span of 1 month. So this is an angiogram. So this is the residual 2 feeders which were still not embolized. So this is a cast after the first sitting of so the other feeders, the residual feeders, other 2 feeders were embolized. Again, provocative test performed first, followed by embolization. So this is the final cast, and in 2 sitting, complete embolization of the vascular malformation was achieved. So this is the follow-up MRI. If you can see, pre-embolization, after first sitting of embolization, there's reduced vascular flow voids, and this is after the second sitting of embolization. Again, showing the resolution of the subarachnoid hemorrhage on the after post procedure. And this is a patient after the second sitting of embolization. So there was no neurological deficit, no significant neurological deficit. His bladder and bowel functions were also preserved. And the patient has a follow-up MRI, a follow-up angiogram, which is also done after 2 years of his embolization. Why a follow-up was done after 2 years was because I also treated his pelvic AVM in a staged manner. So in his last staged embolization of the pelvic AVM, the spinal angiogram also performed, which showed that the spinal AVM there was no recurrence of the spinal vascular malformation. So just to say that, though it may be argued that there was no significant parenchymal component of the AVM, and it was an AVM which is present in the region of the conus medullaris, or in the region of the cauda equina and the lower conus, still there was an anterospinal artery or a radiculomedullary artery which was feeding the vascular malformation. So this provocative test and physiological monitoring gave us confidence to proceed with the embolization so that we could achieve a complete cure. The next case, again, a 69-year-old male who presented with the progressive weakness and all typical symptoms of spinal dural vascular malformation. Spinal dural arteriovenous fistula, arteriovenous fistula, which is in the form of progressive weakness of the lower limbs, numbness of bilateral lower limbs, that is sensory symptoms, and bowel and bladder symptoms. The imaging showed multiple flow voids with vasogenic or venous congestion seen as cord hyperintensity extending from the conus medullaris up to the dorsal cord. So this is an spinal angiogram. So there was an arteriovenous fistula. The fistula site was not in the region of the neural foramen, was rather within the spinal canal. So he actually had two feeders. So he had a feeder from the from L1 right-sided L1 lumbar artery, and also he had a feeder from the right T2 intercostal artery. Now, if you see, both these arterial feeders had a common site where the fistula was there, and this fistula site was not within the region of the neural foramen, but rather within the spinal canal. So this is the selective microcatheter position of the position before embolization, and this is post embolization of one of the feeder, and this is the angiogram of the second feeder. Just a video showing the two feeders. So if you can see, both the arterial, the fistula site is not in the region of the neural foramen, but within the vertebral body, and both the arteries are meeting at a single point, and then there is a fistula coming out of a venous drainage happening out of it after it. So this is post embolization. This is a glue injection. So this is this is for the second fistula, and this is the final angiogram showing complete exclusion of the fistula, and this is the glue cast. Now follow-up MRI showing complete resolution of the perimeter flow voids and parenchymal changes. Now the idea of showing this case was that like a typical, this is not a this is an epidural arteriovenous fistula. So unlike a dural arteriovenous fistula where the fistula's point is at the neural foramen or in the nerve root sleeve, and they generally have only single feeders. Very rarely you see multiple feeders in them. Whereas in epidural arteriovenous fistula, the fistula's point will be within the spinal canal along the retrocorpular or along the lateral wall of the bony spinal canal. So just to highlight this different, and they will have multiple feeders. So this is what one needs to keep in mind, that whenever you're looking at fistulas like this, be a lookout for other additional feeders which has to be embolized, otherwise the treatment will be incomplete. The next case, so this is a 62-year-old female who presented with severe backache. So MRI showed a subarachnoid hemorrhage. There was no evidence of vascular malformation or perimedural flow voids. So a spinal angiogram was suggested. So this is her MRI. You see subarachnoid hemorrhage, which is seen as hyperintensity on T1 weighted images. There's no definite flow voids which is seen in, within the spinal canal. Now, this is an angiogram. So you see, what you see is a faint artery which is coming from on lumbar artery injection. This is a L1 lumbar artery injection, and then there's an ectatic segment. So this is a 3D image. So this is actually a dissecting aneurysm or aneurysm of the postspinal artery or the radiculopial branch. Her subarachnoid hemorrhage was because of the rupture of this dissecting aneurysm. Now, if you look at the caliber of this artery, it is very thin. So, navigating any catheter through this artery to this to the site of the aneurysm will be extremely difficult or extremely challenging. And there is also filling defect or thrombus which is seen within this aneurysm. Now this is an angiogram. This patient was taken up for the intervention. The idea was to try to navigate the microcatheter into this artery and try to reach as close as possible and embolize it. But if you look at the caliber of the artery, it was extremely difficult to navigate the artery, navigate the microcatheter into the artery. So this is where the microcatheter tip is. So then what we did was that we blocked the lateral and the posterior branches of the lumbar artery. Now, this is the coil which is placed in the posterior branch, and then then a coil is placed in the lateral branch. So we blocked these two arteries with the coil, and then injected glue close to the origin of this artery from which the aneurysm is arising, so that hoping that some percolation can happen from this and into the, or it will block the spinal branch of the lumbar or intercostal artery. So the angiogram should complete occlusion of the artery, and then the patient had a good neurological good recovery with follow-up imaging showing resolution of the subarachnoid hemorrhage. She didn't have any recurrence of subarachnoid hemorrhage or any new symptoms on follow-up. So the only thing what I want to highlight here is that if you're not able to navigate a catheter closer to the aneurysm, the other option is block all the outlets through which the glue could get dissipated or go away, and then try to force the glue to the site of origin of this artery which you're trying to or intending to block. So this is a follow-up MRI showing complete resolution of the subarachnoid hemorrhage. So coming to my last case, so this is a 42-year-old male who presented with 3 days history of CSF rhinorrhea from his left nostril. There was no history of trauma or prior surgery. So this is his first MRI. Now, if you look at the MRI, this is the CT, this is the coronal cyst images, and this is the sagittal image. So on the sagittal image, you see there's an widened sella, partial empty sella. If you see the venogram, there is bilateral transversinous stenosis, and there is a lateral sphenoid encephalocele. So this is there is a pneumatized sphenoid, lateral pneumatization of the sphenoid bone which is filled with fluid, and then there is an encephalocele. So this encephalocele was possibly the cause for his CSF rhinorrhea. If you look at the opposite side, there is an intraosseous meningocele, means the bone is still intact. There is no herniation of the brain or meninges through the defect, but there is marked thinning of the bone. So you have an intraosseous meningocele or encephalocele with the intact bone. You have an encephalocele with the fluid filled within the lateral recess of the sphenoid sinus, which is causing CSF rhinorrhea. And he has all features to suggest he has an intracranial hypertension. So probably it's an intracranial hypertension which has led to these encephaloceles and then leading to the CSF rhinorrhea. This is the CT done at the same time. Again, in addition to these two defects, we see a third defect which is also seen in the tegment tympani. So this is a roof of the middle ear. You also see a defect here. There's a fluid which is also filling the middle ear at that time, but there is definitely a bony defect at that site. So because the CSF leak was from this meningocele, he was taken up for transnasal repair of this CSF leak. So transnasally, the leak was identified and the defect was sealed off and repaired. Now, he presented to us after a few months with altered sensory. So imaging done now showed that he had pneumocephalus. Pneumocephalus, which was with air in the subarachnoid space and also air in the ventricles. Now, if you see, previously there was a intact bone in this region, but now there is a bony defect. There are air loculi which is seen in that region, and also there is an hypodense area which is developed in the adjacent temporal lobe. And a follow-up imaging showed that there was a progressive increase in his pneumocephalus and pneumoventricle, and there is diffuse effacement of the cell size. So he was going in for tension pneumoventricle. So at the time of his first surgery, after they repaired his sphenoid leak, because he had features of intracranial hypertension, a thecoperitoneal shunt was placed so that it can manage his intracranial hypertension. Now, at the second time, he has a thecoperitoneal shunt, but now he has come with altered sensorium with imaging showing features of pneumocephalus and tension pneumoventricle. The previously treated encephalocele in the left lateral sphenoid is still persistently occluded, but however, there is now a new bony defect corresponding to the previously seen area of a intraosseous meningocele or a encephalocele, and there is hypodensity in the brain in the adjacent region. So now again he was taken up for the surgery, and the new defect which is seen now was treated. At the same time, they looked at his thecoperitoneal shunt. They saw that the thecoperitoneal shunt was over-draining. So it was revised and a new thecoperitoneal shunt was placed. Again, this is a follow-up. So after the second surgery, after treating this defect in the sphenoid, on the second time, his pneumoventricle and pneumocephalus resolved, his mass effect resolved, and the hypodensity which was seen in the temporal lobe, which would probably mean that the secondary to a leak or secondary to a defect at that site, it's an abscess which is forming or encephalomalacia which is forming, that was also showing a resolution. Patient was discharged home without any neurological deficit. He came back again after a few months with similar symptoms of altered sensorium, and this time he says that he had a hissing sound in his right ear. Again, imaging now shows that he has pneumocephalus. Now, interestingly, the pneumocephalus is seen only in the right hemisphere. It is along the subarachnoid space. There's no extension into the ventricle. Also, if you see, there is subdural effusion which is seen on both the sides. Now, if you look at the venogram now, the venous stenosis which was there in the prior scan has resolved. The venous stenosis has resolved. Now, if you look at the sella, the pituitary also looks bigger than how it was when he presented to us. This is the both the lateral sphenoid recesses which have been treated with endovascular, and it is packed well and it is sealed, and there is no evidence of leak or defect in that region. But if you have a closer look in the region of the tegment tympani, now this is the same site where he had a break which was seen on the prior CT scan. If I go to the prior images, so this is the same site. Same site. Now we see airlock line in this region. So this is the axial image. So if you look at the images, he has features of intracranial hypotension. Probably the intracranial hypertension which was treated with a thecoperitoneal shunt now has converted into intracranial hypotension, which can be explained by the presence of a thecoperitoneal shunt. And also he has a recurrence of a pneumocephalus. Now probably the site of the leak is from the defect in the tegment tympani. At this time point, his thecoperitoneal shunt was removed. Patient recovered well. The pneumocephalus resolved, and he was sent home. On follow-up, there was no recurrence of pneumocephalus, and patient was doing well. Now, what this case highlights is that somebody who has a features of intracranial hypertension or who has intracranial hypertension, they are bound to have multiple skull-based defects. This is because of persistent pressure which leads to erosion of the bone and then the dura and leading to osteodural defect. So whenever you are evaluating any such patient, have a hawk's eye to look for all possible defects which are there in the skull base and mention them. The second thing what this case highlights is that by placement of a thecoperitoneal shunt, what was created was a negative pressure within the calvarium. Because of an over-draining thecoperitoneal shunt caused a negative pressure within the calvarium, which led to these recurrent pneumocephalus through the pre-existing defects in the skull base. So the pre-existing defects in the skull base where the cause for his recurrent pneumocephalus, which was due to a negative pressure created by an overdraining thecoperitoneal shunt. Now, this overdrain of the thecoperitoneal shunt is apparent because his intracranial hypertension is now got converted to intracranial hypertension. So, while reporting any of these such cases, this is what one needs to always keep in mind. Thank you.
Thank you, sir.
So, I've shared cases. If there's questions I can, or any queries or any suggestions on how these cases have been managed, it'll be open for the discussion.
Okay, thank you, Savith. Anybody, any questions? You can ask questions.
Sir, how frequently you do provocative test?
Pardon? I didn't hear you. I didn't hear you. How frequently?
You do provocative test before embolizing, sir. Spinal.
I've done only for 2 cases. This is my first case. I've done one for a intracranial AVM, which was closer to the motor cortex. That's all. Only 2 cases till now.
And what was the indication, sir, in spinal AVM?
I told you, no? The spinal, because most of the feeders were from the radical branch, both anterior and posterior. My fear was that I may create a neurological deficit, and any deficit or any infarct in the conus medullaris region would be causing him long-standing bowel and bladder disturbance. So the whole idea was to, if I pick up any of those changes very early using this neurophysiological monitoring, then I would stop the procedure immediately. So that was the idea of doing a test and neurophysiological monitoring.
Sir, but spinal AVMs, they are usually supplied by ASA or PSA only. So
yeah,
when to decide to go ahead with provocative test?
See, it's like this. If you feel that by your embolization you have a risk for causing a parenchymal infarct, then you have to do a provocative test. Take, for instance, when my provocative test would have shown that by if I had induced a weakness by placing a microcatheter close to the AVM, then I wouldn't have embolized it. I would have left him alone, because patient's presentation was only a separately and a single episode.
And one case you showed that PSA dissecting aneurysm. That aneurysm was small, so like you could have followed up like any literature on like recurrence.
No, I agree. I agree with you. Posterior spinal artery aneurysms, we could have followed it up also, but being a dissecting aneurysm and your risk of causing a significant deficit by occluding a posterior spinal artery is very minimal. So, went ahead with the embolization, considering that the risks are lesser. If it was an anterospinal artery, dissecting aneurysm, I definitely would have left it alone.
Yes, sir. And that one stroke case you showed, sir, what guide catheter you have used in that?
Neuron Max. Neuron Max and 5 French Navion. Initially, aspiration catheter was ACE. Stenting was through 5 French Navion.
Sir, I am ambulance. I have doubts. So this is regarding the carotid artery stenting.
Yeah.
We avoided embolic protection device and used only stents because it is not a straightforward case and with the severe calcified blocks.
Yeah, I see. You can. It can be also argued that why stenting could have sent it for endarterectomy. I would agree, because it was all calcified. There were no soft plaques, only stenting. I would agree with that, but I have not done a single case of carotid stenting without a filter. So I'm still not not in favor of doing any of the carotid stentings without a filter. So because of that reason, I have taken a filter in this case. And I never expected that I will face so much of difficulties after seeing an initial angiogram.
Is there any follow-up of this? And how much is the risk for restenosis and other reactions?